Welcome back to the Anja Health podcast. Today, I'm super excited to have a reproductive psychiatrist with us, Dr. Brittany Booth. So thank you so much for being here and making the trek down from Westlake Village.
My pleasure. I'm excited to be here.
Awesome. Well, I'd love to know more about your background and general experience, especially what got you specifically involved in reproductive psychiatry.
Definitely. So I went to undergrad in Boston and then went to med school at UCLA and decided pretty early on that I wanted to be a psychiatrist. Went to UCLA for psychiatry residency also. I didn't know I wanted to be a reproductive psychiatrist until my third year of residency. UCLA has this amazing clinic that's just an outpatient reproductive psychiatry clinic that's pretty unique. So I signed up for it just because I thought it was an interesting, unique learning opportunity. And then I actually ended up getting pregnant at the very beginning of that same year that I was doing that clinic rotation. And just the intersection between those two experiences, being pregnant and learning how to treat mental illness during pregnancy and then postpartum, was just like so eye-opening, and I just fell in love with it. So I actually went back and I did the clinic again my fourth year when I was in my first year postpartum, and it just added to that same passion for it. So I've never looked back.
That's awesome. So how many kids do you have now?
I have one kid.
Okay, awesome.
Yeah.
Cool. Well, yeah, as you know, we're a cord blood bank, so I'd love to chat briefly about cord blood banking, especially since you have had a baby. So in your eyes, what are the pros and cons to cord blood banking as a reproductive psychiatrist?
So I see a lot of pros, right? I think it's something that's non-invasive. It's really easy to do. Again, with the kits and the resources that are out there, it's really easy and non-invasive to do. And it's just a nice insurance policy. God forbid anybody in your family or your kid gets sick, to be able to have access to this really incredible scientific technology to heal them or cure them is just mind-blowing. And then the cons, depending on the various resources out there, cost I think is probably just the biggest thing that comes to mind, and access to it. But beyond that, I don't really see any sort of cons to it.
Yeah, that's awesome. So yeah, we can skip the if you did it for your kids. But do you have any questions for me around cord blood banking?
It's not something that I had thought about a whole lot before, or was really offered to me actively during my own pregnancy.
Yeah, have you heard of it before?
I had heard of it before, sort of in medical training. It was just, I have faint memories of it, but it wasn't something that I had the perspective that it was really commonly offered or talked about. And so I'm kind of curious how you've seen the awareness about it spreading, if it's becoming more common or popular.
Yeah, I would say it's definitely more common. Like every year they release this report on kind of the cord blood banking market, and it does definitely grow every year. Still around only 2% of parents do it in the United States. But I think it's kind of interesting because in other countries, like in Portugal and China and Singapore, it's as high as 30% of parents doing it. I think in Singapore specifically, it's because they receive a stipend whenever they have kids, so they have a little bit more disposable income to be able to spend on things like this. But but it is interesting. I think the awareness has definitely shifted, especially as OBs are more exposed to it. And in general, I think older OBs tend to be a little bit less inclined, just because it's newer research and they kind of feel like they haven't really been updated on it. But I feel like younger folks like yourself have definitely heard of it through medical training, like you mentioned. So yeah, sort of like the OBs that heard about it in med school enter the field. I think it is becoming more common.
I wonder, if pediatricians would be really more open to it too, since the blood banking happens sort of in the sort of labor and delivery unit where OBs kind of take priority or sort of the head of what's going on. But really the benefits of the stem cells are going to come later, under pediatricians' care. I wonder if they're kind of more open to it.
Yeah, I definitely think so. Yeah, I've tried it with pediatricians too. I think sometimes parents haven't approached a pediatrician per se, or they've kind of barely scratched the surface of finding one. So they don't end up getting as involved in birth decisions. And I think this tends to fall more under like a birth decision. But yeah, I think especially when it comes to use cases, the pediatrician is for sure more involved, especially if the baby has been tested for some genetic condition or is seemed to be predisposed.
I mean, that really ties into what I see as like a healthy postpartum experience, which is not just to focus on the birth plan and what's going on in the labor and delivery suite, but really prepping for the postpartum and new parenthood is, you know, having a plan for what's going to happen at delivery, but also what's the feeding plan for the baby, who's going to help take care of it, you know, God forbid the baby gets sick, how are they going to help get, you know, medical treatment?
Right.
You know, a huge part of the postpartum plan.
Yeah, definitely. Yeah, I feel like when I chat with other folks in the medical space about just postpartum mental health in general, it kind of feels like people spend so much time preparing for pregnancy and birth, and they just kind of end up neglecting postpartum almost because they are just like so busy thinking about what's going to happen throughout pregnancy and birth, and then when postpartum comes, I've had a lot of parents tell me that they feel like totally unprepared and they just like didn't really think about it. And then mental health ends up getting neglected too because there's just kind of a frenzy of things happening. So yeah, super excited for our chat today. Well, before we dive into postpartum mental health, I'd love to chat about pregnancy related mental health as well. So what are some common mental health issues that you found that arise during pregnancy specifically?
So depression and anxiety are really common during pregnancy, actually. There's not necessarily new mental health issues that arise specifically in pregnancy, although people can have sort of new onset issues that rise up. But typically people have a history of mental illness of any kind, depression, anxiety, bipolar, schizophrenia, OCD. Pregnancy tends to be a vulnerable time. It was previously thought that it was a protected time for mental health. And you know, everyone glows and everyone's perfectly happy to be pregnant, and mental illness, you know, sort of quieter. But we actually know that it's a more vulnerable time.
Right. So if you have a history of anxiety or depression and you're currently pregnant, then what are the chances that you will have anxiety or depression during your pregnancy? And what can you do to sort of guardrail from that?
Yeah. So the risk of having another episode during pregnancy sort of varies. It's estimated about 13 to 15% of women or people who are pregnant will have an episode of depression during pregnancy. So it's fairly common. If you have a history of depression or anxiety, the risk is likely higher. There was a study that showed that if you are depressed and you're on medication, you have about a 40-45% chance of having an episode of depression during pregnancy. If you continue on the medication, your risk goes down to 25%.
Okay.
If you stop the medication in anticipation of pregnancy, the risk goes up to about 68%.
Wow.
To guardrail against it, it actually is really important to stay on medication because again, it's not a protected time.
Yeah. Are most medications for depression and anxiety able to be taken during pregnancy as well?
Yeah. Okay. Vast majority of them are.
Awesome. Okay, cool. So how can you emotionally prepare for pregnancy, or wait, how can you emotionally prepare for pregnancy if you have had anxiety or depression in your family's history, but you may not necessarily have encountered it yourself?
If you have a family history of it may slightly increase your risk of having it, but really the personal history of having depression or anxiety is what puts you at much greater risk for having it during your own pregnancy or postpartum. But even still, you know, everybody has things in their life that they've dealt with. You know, having a family history of any kind of mental illness may have impacted that person's life. And so I just sort of generally blanket recommend, you know, it never hurts to talk to a therapist. Unpack your own childhood, unpack, you know, the different things that have happened to you in your life, because you're embarking on this huge transition in life. You know, becoming a parent is a huge, huge deal. And depression, anxiety, even put aside, just emotionally preparing for that transition and that new role in your life can really be aided by the help of a professional.
Right. Okay, awesome. What risk factors should pregnant parents be aware of when it comes to developing postpartum depression or anxiety? And what should they just kind of look out for? Any warning signs or anything like that for when they should specifically seek help? Or do you recommend seeking help as a preventative measure? And when should that happen?
Yeah. So specific risk factors to think about, again, the most prominent ones that put you at greatest risk for developing depression or anxiety during pregnancy and postpartum is a personal history of mental illness. So if you've had it before, it's a vulnerable time to have it again. If you have active depression or anxiety during pregnancy, that significantly increases the risk for postpartum issues. So stability predicts stability, instability predicts instability.
Right.
The best thing that you can do is get treatment for it as soon as possible. And actually preventative treatment is the best. So if you have a history of depression, anxiety, but it's well managed, it's quiet, whether on or off medication, having the input of a mental health professional, whether that's a perinatal therapist or a psychiatrist, to just talk about what your risk factors are, talk about kind of monitoring actively during pregnancy so that if there is any kind of whiff of recurrence, that you can get it really quickly.
Yeah. Okay. Interesting. So if someone is currently pregnant, when should they seek out mental health support, like as a preventative measure? Do you recommend that they're kind of doing it when they're trying to conceive? Or at what point would it be helpful to specifically seek out a reproductive psychiatrist?
Well, psychiatry specifically when there's a question of medication. Usually if people have never been on medication before, they won't come to the thought of starting medication for the first time ever when they're getting pregnant. That's usually not when they're first seeking it out. It's usually when they're actively depressed or anxious, even if they've never been on medication before. Then they'll come to see a psychiatrist, even if it's during pregnancy. But really seeking mental health help at any time, prior to conception, during the first trimester, before or after you feel depressed, anxious, having more OCD symptoms, whatever the symptoms are, the diagnosis is, the sooner that you seek help, the better.
Yeah. Okay. Good tips. How do pregnancy hormones typically contribute to depression and anxiety?
That's a complicated question.
Yeah.
Because for some people, they really can, again, like I said, it's a vulnerable time, but there are some women who say that they have never felt better than when they were pregnant. So there are a few women that really does hold true, and the pregnancy hormones really kind of calm things down. There are some women that are just more sensitive to fluctuations in hormones, and pregnancy and postpartum is just a period of time where there's constant fluctuation. And so women that are a little bit more sensitive to that might have a really hard time, especially in the postpartum. There's this steady increase of your hormones during pregnancy and then just this precipitous drop at delivery. And that can be a really, really hard time.
Right. I'm curious if any hormonal changes that you might experience throughout a menstrual cycle can be predictive of any hormonal and mental health side effects you might have as a result of that during pregnancy.
Yeah, I think we need more data on that to really see if there's a true association between women who may have, diagnoses of PMDD or premenstrual dysphoric disorder and who experience postpartum depression. Just from a clinical standpoint, I do see a bit of a pattern that can happen, that women who have a bit more mood fluctuation during their menstrual cycles might have a bit more of a hard time in postpartum as well.
Right. Okay. Sorry. Is that one okay?
Yeah, so that battery kind of died too.
Oh, okay.
But this one seems okay, so I think this is going to get us through.
Okay, cool. Are the others still good?
Let's see. Yeah.
Okay. Okay, awesome. Yeah. Okay. Sorry about all the technical difficulties.
It's okay.
I feel so bad.
It's okay.
It's still rolling. Let me
Okay.
just hit record real quick. And yeah.
Okay. Awesome. So how can you tell, or let me start. So I feel like during pregnancy, anxiety tends to be relatively common, like even for things like kick counting, when I've talked about on my platform, I get a lot of comments around like, I don't really like to kick count because it creates anxiety, and I already have so much anxiety around all of the potential things that could happen during pregnancy. And I feel like some parents just kind of naturally feel a state of anxiety, especially if they're a first-time parent. So how can pregnant parents decipher between very serious anxiety that requires mental health support versus kind of just normal worries that any first-time parent might naturally come across?
It's a huge gray area because anxiety and worry is almost an inherent part of that process. And, and rightfully so, right? You should be concerned about the health and the safety of your pregnancy and your baby. That's part of being a parent. But when it's becoming excessive, you're spending too much time thinking about it, the thoughts about, what if this happens? What if that happens? Are becoming really sticky. It's hard to, get off of that thought and switch directions once it happens. It's becoming more irrational. Like, what if, sorry, I can't think of a specific example, so we can just cut that part out. But if it's becoming, more irrational, and the thoughts that you're having just aren't likely really to happen. If it's really eating up a lot of your day and causing a lot of distress, or interrupting your sleep or your appetite or your relationships or work, that's when it's really getting into more clinical levels of anxiety. Right. If you're not sure, again, seeking the perspective of a mental health professional who can help kind of walk you through that and tease it apart and decipher with you, is this normal kind of parental worry, or is this really getting to a point where that needs treatment? Even if it's somewhere in the middle, a therapist can help with coping skills and ways of talking back to the thoughts so that they don't eat up as much of your time or cause as much distress. Right. Okay. So even if someone is experiencing kind of the normal worries, and especially if they aren't experiencing just normal worries and it's beyond that, what would be your top 3 self-care tips for mental health specifically when it comes to postpartum depression and anxiety, but also even during pregnancy? Sleep. Sleep is huge. It's a major contributor to mental well-being. So sleep is really hard in pregnancy and postpartum. In pregnancy, there's just the anxiety and the worry, but there's also just pregnancy-induced insomnia. And then in the postpartum, everybody has problems sleeping. Right. But working with potentially your doctor to see if there's any help with sleep aids that you can take, working with a therapist who can do cognitive behavioral therapy for insomnia, which is the best, gold standard first line treatment for insomnia. Doing that would be incredibly helpful. But really just figuring out ways that you can improve your sleep. And we can talk about what that looks like in the postpartum a lot more. Maybe a little bit later. Yeah. That's a whole separate thing. So sleep is a major one. Distribution of household labor is another one. So self-care could mean not taking on as much of the mental and visible load of household management during pregnancy and postpartum, and really getting your partner practiced in doing more household labor during pregnancy so that you don't have to sort of scramble to figure that out in the immediate postpartum. But really getting your partner to anticipate what needs to be done, not just, tell me what to do and I'll do it. That's not as helpful, but for your partner to really be able to look and anticipate and make that own mental checklist for themselves and then carry out tasks can take a huge load off of women. Yeah. Excellent tip. I think it's interesting that you mention sort of partner support, because I feel like those are habits that you can start to institute during pregnancy, and especially when it comes to things like breastfeeding. I've had lactation consultants on our podcast, for instance, that have stated that partners should really begin to be helpful during breastfeeding and can really provide that extra support. So what other lifestyle changes do you feel like parents should begin to do during pregnancy in order to be able to protect against poor mental health in the postpartum period? So having a really good postpartum plan, kind of planning ahead. Again, not just for delivery. Everyone thinks about delivery because it's big and it's scary and, painful, right? And you want to prepare for that as much as possible. But like you said, everybody forgets about the postpartum.
Yeah.
And so thinking really proactively about what are the different feeding options for the baby and my openness to them, and creating a really flexible plan. Having your partner, again, be well acquainted with not just helping, but being a active, equal member of the household and really pulling their weight, so that it's not just he works and I do this. You're both active members of taking care of the home and the baby. Sorry, lifestyle modifications. I'm just sort of thinking about how to like phrase things. It's not often like lifestyle stuff, like exercise and stuff. It's like,
yeah, that makes sense.
Yeah.
I think it's interesting you mentioned, the sort of partner support again. And, if someone is a single parent, what kind of tips do you have for them to prevent against postpartum depression and anxiety? Because I feel like especially in those instances is when the lack of sleep might be even more dire. I'm curious about that.
Yeah, it's a hard one, right? Whether people are a single parent by choice or just by circumstance.
Right.
Trying to build up your support and community outside of just a romantic partner or the other parent is absolutely crucial. And that can be found in a number of ways, but people may need to actively work to build up that community a bit more. And that really depends on their resources, right?
Yeah.
Some people may be lucky enough and resourced enough to afford full-time nanny or doula, or some people may have family around, not a partner, but family that can pitch in. Some people really are quite isolated for whatever reason. And so working to, meet neighbors or join a church or religious community where people are more likely to pitch in and help. Seeking out friends who maybe, even if they're far away and they can't come physically, if anyone's able to organize an online meal train to get some meals delivered, whatever they can do to help get any kind of support from other people, whether that's immediate physical support or whatever support can be given from far away.
Right.
That's going to help the most.
Yeah, I remember earlier this year when the CDC published that study that 80% of pregnancy-related deaths are preventable, and one of the leading causes is mental health issues. So I remember that article cited specifically finding community and just being super intentional about that. Whether it's a Facebook group or anything like that, just someone that you can kind of rely on. Yeah,
and the support that I was just talking about was sort of the care support, right? But finding community and people to relate to and vent to, and just talk about the transition into parenthood with is super important. So that that can be Facebook groups or social media. It can be a bit of a minefield as well. You have to be really intentional about the accounts you're following or the people that you're engaging with on social media. Postpartum Support International is an incredible organization that has just dozens of free online support groups, just general support groups for moms, but then also different, more specific ones for different demographics, different parenting setups, so single parents or same-sex parents, different kinds of groups, so that if, again, you need some kind of community to just feel that emotional support, that's an incredible resource.
That's a good tip. Yeah, I actually didn't know about that organization. I've heard of Peanut, sort of like Tinder for parents.
Yeah.
Do you typically recommend that as well?
I don't typically recommend it. I don't not recommend it. I think it, for finding people who are in the same boat and you can actually meet up with, I think it's great.
Yeah.
But if it's not really working out, again, PSI, or Postpartum Support International, is also a professional organization. So the groups are also run by perinatal mental health professionals.
Oh, okay. Yeah. Amazing. That's awesome. Cool. Well, I wanted to pivot a bit into sort of medications, especially since you're a psychiatrist.
Yeah.
So I know we chatted about medications being safe during pregnancy for the most part, but are there any medications for OCD, anxiety, and depression that you can't take during pregnancy?
For OCD, anxiety, and depression, the short answer is no. There's no medication that you absolutely cannot take because they're all OCD, anxiety, and depression are all treated with antidepressants, SSRIs, SNRIs, potentially bupropion or Wellbutrin, and mirtazapine or Remeron. Those are sort of big antidepressant classes.
Yeah.
And all of them have sufficient data to support their safety.
Yeah.
We typically think that we need about 700 cases of exposure of a medication in pregnancy to really feel comfortable knowing that there's no real increased risk of anything happening, and we have that amount for all of those meds.
Yeah. Okay, amazing. Can women with OCD and ADHD also stick with their medications typically? And in the case that they do have those, do you have like any guardrails that you would recommend? So
for OCD, we use the same meds as for anxiety and depression, so it's mainly treated with antidepressants, so no question about that. For ADHD, it's a little bit more of a nuanced conversation. We don't have as much data on the stimulants as we would like. Again, we haven't really hit that 700 number, so we have a small amount of data. What we have is overall reassuring.
Yeah.
Nothing to suggest that people need to immediately stop their medication when they get pregnant, or freak out if they're on it and they accidentally get pregnant.
Right.
The small amount of data that we have suggests that there may be very, very, very small increased risks of preterm labor or small birth weight babies, depending on which trimester the medication is taken. But again, we need a lot more information to know if those are real findings. If they are real findings, again, the increase in risk is really, really, really small.
Yeah.
And when we're thinking about whether or not to take a medication in pregnancy, the risk of medication exposure is one thing to keep in mind, but it tends to be overvalued, and the risk of it tends to be overestimated. The risk of mental illness during pregnancy is the thing that gets forgotten about and underestimated.
Right.
So we know this from the data in antidepressants that actually untreated mental illness during pregnancy, depression, anxiety, some of that depression, anxiety that can come from untreated ADHD, right? That is actually associated with poor outcomes. Preterm labor, small birth weight babies, preeclampsia, long-term neurodevelopmental outcomes in kids, learning and behavioral issues, things like that. And so what we know from the antidepressant data is that actually taking the medication during pregnancy may mitigate those risks rather than increase the risks. It used to be thought that the medications caused those poor outcomes. The early data, showed that association between medication and those poor outcomes. But the more recent data has really shown that it's not the medications, it's the underlying mental illness.
Right.
And so when we think about the ADHD treatment where there may be a bit more risk with the medications themselves, first of all, we still don't know that for sure.
Yeah.
But the risk of not taking them might actually outweigh the risk of taking them. But it's a more nuanced conversation about the severity of the ADHD, how much it impacts their lives if they're not on their medication.
Yeah.
And that conversation really should happen with someone who's well-versed in the risks of the medication, and that's typically specifically a reproductive psychiatrist.
Right. Yeah. That's definitely interesting. I think, I'm actually on Keppra, the medication, because I have a history of seizures. And so, I remember when I first got on the medication, I was 18, but my mom was like, what if you're on this for life? What if you try to have a kid and stuff like that? But, I feel like the risk of potentially having a seizure would, outweigh anything else. That's definitely a good framework.
Yeah. It's individual to each medication. You know, Depakote is another anti-seizure medication that's really commonly used, and it's actually one of the ones that's used both in neurology and psychiatry. But Depakote is actually one that in psychiatry is our biggest no-no for pregnancy. That's really the one medication, if you were to ask me what's the one medication that you cannot take in pregnancy, that's it. Okay. So again, it's individual to each medication. I was kind of talking broadly about the antidepressants, but if you're on any medication and you have questions about its safety in pregnancy, it requires a nuanced conversation.
So Depakote is mainly used to treat seizures.
So it's used to treat seizures in neurology. In psychiatry, it's used as a mood stabilizer in bipolar disorder.
Okay, interesting. Awesome. Well, I'd love to move into postpartum mental health, since you said that is very frequently neglected, as we chatted about. So how soon after birth can postpartum depression start, and what are really initial symptoms that you feel like parents should look out for?
So there seem to be kind of different subtypes of postpartum depression. Sometimes it can start to rear its head in the third trimester. Sometimes it presents really early on. I've had some people say that it presented immediately following birth, or in the first 4 weeks or so. And for some people, it can take a few weeks to kind of set in. So it varies. When it happens in those first few weeks, or when you start to develop symptoms in those first few weeks, it can be a little bit difficult to differentiate from baby blues or postpartum blues, which is exceedingly common. About 85 to 90% of women will have baby blues. So that looks like more crying, this sort of mood fluctuation, or they feel a bit more labile, just their emotions kind of feel everywhere. They may be worried and different things, but it's typically not so severe that it's impacting their function. They can still take care of themselves, take care of the baby, get everything done, and the relationships are not really being tested. It's self-limited. It goes away by itself without treatment within 2 to 3 weeks. So if you start to develop symptoms right in that window, sometimes it's best to just wait, a little bit to see if it's petering out. But if it's really severe, you're having really, really dark thoughts, wanting to die, or thinking that your baby or your family would be better off without you. If you're unable to sleep, even when given the opportunity, not eating or eating too much, or like going back to sleep, sleeping too much, feeling really detached from the infant. Your mental health is really impacting your ability to engage in your relationships with other members of your family. Those are signs that real true depression is setting in.
So what causes baby blues versus postpartum depression?
So there's probably some overlap. Baby blues is, most likely just an adjustment to this giant, again, drop in hormones right after delivery. And that adjustment period is, it actually takes several years for the full adjustment to hormonal changes, but from that precipitous drop, those first couple of weeks are a bit shaky. Postpartum depression can be multifactorial. Again, it can be its own isolated thing where it's a response to the change in hormones. It could also just be a recurrence of an existing major depressive disorder.
Okay, so you mentioned that baby blues is common in around 85 to 90% of new parents, but how common is specifically postpartum depression and anxiety?
10 to 20% of women will have postpartum depression or anxiety, but your risk for that, is higher or lower depending on your own personal history. If you have a history of depression or anxiety, if you're depressed or anxious during your pregnancy, your risk is going to be higher.
Okay, and if you've had it before, if you've had, for instance, another child that you experience postpartum depression and anxiety with, is it then more likely that you'll experience it again with future babies?
Yes, with a caveat. So if you've had a history of postpartum depression, you are more likely to have it again, about 50%, risk of having it again. The caveat is if you don't do anything different. if you were not on any kind of medication, treatment, or in therapy or anything during your first pregnancy, but during your second one, you say, I don't want to deal with that again. I don't want to experience that again. I'm going to get therapy. I'm going to start medication or continue the medication that I've been on, since that episode.
Yeah.
You're going to mitigate that risk. And the risk of it happening again is going to be significantly lower.
Right. Yeah. Yeah. It's interesting. We had an OB on our podcast who said that they actually feel like a postpartum depression and anxiety is better managed when the parent has experienced it before in life, whether or not it's within a pregnancy context, because they have already sort of built up the habits towards management. And it's actually the people that have never experienced it before that end up having kind of like more chaotic coping experience.
Yeah.
Yeah. Okay, awesome. Let's see, we already answered that one. So yeah, I feel like in general, there are a lot of sort of misconceptions about mental health, especially around the postpartum period. So what do you think are the most common misconceptions and what are the correct stances on them?
Yeah. So major misconceptions in the postpartum. One thing that really doesn't get talked about a lot is postpartum OCD.
Okay.
Or OCD symptoms.
Yeah.
So there's, first of all, a lot of misconception about what OCD in general is. It's not just about being clean or fastidious or keeping everything at right angles. Sometimes it is. But really what OCD is these unwanted, distressing, immediate intrusive thoughts that just pop into your head. Those are the obsessions. And the compulsions are these behaviors that people take to reduce their anxiety that those obsessions bring.
Right.
So those obsessions or those intrusive thoughts are actually incredibly common in the postpartum, even in women who have no history of OCD or even mental illness in general.
Yeah.
Just it's some kind of evolutionary mechanism to kind of probably keep your baby safe. But many, many women will have these immediate thoughts of harm coming to their baby, harm coming to themselves. Sometimes it's images of them dropping their babies or, picking up a knife and doing something terrible. It can vary in so many different ways. But it's not very widely talked about. And so it's common, not widely talked about. And so there are tons of women out there experiencing this and not knowing what it is and thinking that they're like going crazy or that they want to do that. And the important part is the emotional response to the thought. If your response to the thought of harming your baby is, maybe that might be necessary or that, I might want to do that. That's terrifying and it needs emergent, care. That's very, very concerning. Very, very rare though. Most of the time, the response to that thought is horror. Oh my gosh, no, I don't want to hurt my baby. What does that mean about me?
Yeah.
The response is guilt and shame and horror, right? Knowing what that thought is, knowing that it doesn't mean anything about you, about your fitness as a parent, about how much you love your baby, that can be really healing in and of itself, just knowing what it is. If it's getting more severe, if they're constant, you can't unstick yourself from them, you're starting to avoid certain things to manage the anxiety that comes with them, then you're really getting into kind of diagnosable postpartum OCD, and that will require treatment. But just having those thoughts by themselves doesn't necessarily mean that you need treatment. Just kind of knowing what it is can be helpful enough.
Okay. Yeah, that's really interesting because I've never chatted about specifically postpartum OCD on this podcast. So I'm glad you're here.
I would say another misconception is that every parent feels that immediate magical bond and attachment and all-consuming love for their baby.
Yeah.
That's the norm. That expectation can set up a lot of distress and disappointment, again, guilt and shame,
right,
if it doesn't happen.
Right.
Actually, for a lot of people, I venture even to say most people, it doesn't happen that way. It takes time. You're meeting this brand new person. It takes time to get to know them and for that bond and emotional attachment to gradually build up and develop.
Right.
So I think managing that expectation that that's going to happen can help alleviate that stress after the fact.
Right. Do you find that that happens more frequently with dads, that they have trouble building a connection?
Not trouble building a connection necessarily, but I think it's actually really common for both parents. It's just that moms are kind of primed to expect that immediate attachment.
Right. Okay, awesome. Well, I think another really interesting sort of conception around postpartum depression and anxiety is that a lot of folks just don't seek treatment and don't even tell anyone that they experience it. So I think it's really interesting that very recently the FDA approved a medication specifically to treat postpartum depression and anxiety. So what is your take on this medication? Have you begun to prescribe it? Should this be something that parents should really consider?
Yeah, this is a really, really exciting time to be treating postpartum depression.
Yeah.
It's the first, novel treatment that we have in this new mechanism. There's a similar medication to it that's been around for a few years, but it's really complicated to get. And I think less than 1,000 people have actually gotten the treatment since it's been available.
Why is it so difficult to get?
So it's the same mechanism of action, but it's an IV infusion that it's like a 60-hour infusion. You need to be admitted to a hospital and observed for that long. There's only a few centers that are even offering it. I think only 4 in California. And it's not covered by insurance and wildly expensive.
Okay.
So just across the board, really inaccessible.
Yeah.
But this new medication that was just approved, it's the same mechanism, but available in a pill form. It's a 14-day treatment that's taken immediately postpartum. And the data for it is really exciting. So it's a 14-day treatment. The study studied it in people who are on antidepressants and also not on antidepressants. So safe to take it with other meds if you're already on them. And it really seemed to work. It separated from placebo within 3 days of starting it. And that improvement sustained until the end of the study, which was 45 days after starting treatment. So it's about a month and a half, right? We need more studies to know its longer term effect, if it wears off after that or what. So there's still a lot of unanswered questions, but the fact that there's this new treatment that seems to be really effective and really quickly, that's really the main difference, is it worked in 3 days.
Yeah, wow.
Yeah.
Okay.
We need more information about its safety during breastfeeding. So in the study, even though these are immediately postpartum women, they were told to stop breastfeeding because, again, we don't have any safety data yet.
Yeah.
So we don't have any more safety data on it from these initial studies. We need more to really know. But so for the 14 days of treatment, it's not that they have to just give up breastfeeding completely if they don't want to. They may pump and dump for the period of treatment and then a week afterward. But we just need more data on that.
Right.
I haven't prescribed it yet because it's actually not, it's approved, but it's not available yet. It will likely be available by the end of this year.
Okay.
Yeah.
Do you think you will prescribe it?
Yeah.
Okay.
Yeah.
Awesome. Cool. Well, I know we chatted about sort of dads and any connection that they might be missing or anything like that. But how can dads best support moms that are experiencing postpartum depression and anxiety? And do you find that dads actually experience it themselves?
Absolutely. About 10% we think of dads may experience postpartum depression and anxiety. And what we actually know is that when one partner has postpartum depression or anxiety, the other partner is more likely to.
Right.
And so even one partner getting treatment and having one mentally, emotionally well parent is really good for the baby.
Okay.
So it's really important to recognize it, address it, get it treated.
Yeah.
If dad isn't depressed though, and mom is, the ways that dad can really help, similar to what we talked about before, being really proactive about picking up what mom can't do at that moment. Housework, baby care, all these different things. Not asking what needs to be done, but anticipating, knowing, hey, there's a pile of laundry, the dishes are piling up, we need bottles to be cleaned. We need groceries or A, B, C, D.
Yeah.
If mom doesn't have mental health care already set up, dad can help reach out to professionals, or if they don't know who to reach out to, dad can reach out to mom's OB and say, she's really struggling. Do you know anybody?
Right.
With HIPAA laws, physicians can always receive information. They can't disclose any information. But if someone's concerned about their loved one, they can always call somebody's doctor and say, I'm concerned about them. Can you help?
Okay. Do you find that similar dynamics play out in same-sex couples or even like surrogate parents?
It's complicated. We need a lot more data.
Yeah.
But generally speaking, gender roles tend to be a bit more evenly divided in same-sex couples. Granted, there are always individual variation, right? But it's not as, clearly societally imposed on them.
Okay. So if you are currently experiencing postpartum depression, anxiety, what are your top 3 tips for coping with it?
Get professional help is 1, 2, and 3, honestly. Find specialized care. So there are general therapists and general psychiatrists, and they're wonderful, but this is a very specific time of life that requires specialized care.
Right.
And so a reproductive psychiatrist who knows the data about medications and breastfeeding is going to be really important if that's necessary, because a lot of general psychiatrists, and this is true actually in pregnancy as well, general psychiatrists don't receive a lot of training in managing meds during these times, during their residencies. Again, I came through UCLA, and if I hadn't done that one specific clinic, I may have had 2 pregnant patients my entire training career. And so that's what most sort of community psychiatrists are coming from. And so they practice defensively when it comes to medical legal issues, right? They don't want to be responsible, God forbid, if something were to happen and they were prescribing something during a pregnancy. And they're not keeping up with that same data that reproductive psychiatrists are.
Right.
So they could go find a psychiatrist, but they may not be willing to prescribe anything during breastfeeding.
Yeah.
Finding the right kind of care is super important. And then same thing with therapy. Therapists can go through a specific training and get a certification called PMHC, or perinatal mental health certification. And so if you're trying to find a new therapist for specifically pregnancy or postpartum depression, finding a therapist with the letters PMHC is really important.
Okay, awesome. So with and without proper treatment, how long can postpartum depression and anxiety last?
Without proper treatment, it varies a lot, but I've seen people who have really extended episodes, even a year plus after they deliver.
Is that largely because hormones take such a long time to stabilize?
It may or may not be because of hormones. It might just be that they had, again, this sort of pre-existing depression, and theirs might be a depression that doesn't typically resolve without medication.
Okay.
It's hard to say exactly why certain cases last longer. With proper treatment, the nice thing about postpartum depression and anxiety is it tends to be really responsive to treatment. And so with proper treatment, you can be better in, a couple of weeks, maybe a couple of months, depending on how severe and response to treatment and things like that. But much more quickly.
Yeah. Okay, amazing. Well, I'd love to chat about breastfeeding in particular, because I feel like more recently I've been seeing more content around breastfeeding and mental health, and especially parents that feel guilty for having a low milk supply or for starting to pump more or anything like that. So I just feel like there's a lot of unresolved feelings around breastfeeding that tend to not get discussed. So I'm curious to get your personal take on how breastfeeding can impact mental health and what you should look out for during a breastfeeding journey in order to protect your mental health.
Absolutely. It's really complex. Some people have a beautiful breastfeeding journey. It's easy for them. Their milk comes in naturally. They have a good supply, no problems with latching. They find it emotionally rewarding, and it goes very smoothly.
Yeah.
That is the assumption is that that's the norm, and that everyone will experience that. And that's simply not the case. It can be complicated in a multitude of ways.
Yeah.
There can be problems with supply, like you said. There can be problems with latching or tongue tie in the babies. There can be a lot of pain. It can be a really painful process for mom to breastfeed. Moms might feel really resentful about pumping. I have yet to meet someone who loves pumping. It's either just tolerated or absolutely despised, but they just do it because they really want to continue providing breast milk. But it can take up, just a ton of time. You're just sitting there while you're pumping for 20, 30 minutes, multiple times a day. Depending on if you're exclusively breastfeeding or pumping, you're also not able to get any sustained sleep. Because either you need to be nursing your baby every few hours, or if you're pumping, you need to be pumping usually every 4 hours or so to keep up your supply.
Right.
And so just by nature of that, you're not able to get any sustained sleep. And what we see is that getting at least 5 to 6 hours of sustained sleep is kind of a game changer for mental health.
Yeah.
Postpartum period or not.
Yeah.
And so it can impact mental health in all of these really different ways. And like you said, if it's not going the way they anticipated, there's this enormous amount of guilt and shame that can come from that. They feel like they're failing as a mother. They're not fit as a mother. They can't feed their baby. And what I actually find is that the flexibility about the feeding method is the biggest predictor of breastfeeding's impact on mental health. This is based on my clinical experience. This is not based on studies or evidence, but in seeing many, many, many pregnant and postpartum women, if women go into the postpartum and this feeding journey with this very tightly held, rigid plan to breastfeed only, formula is not even an option.
Yeah.
That can really set them up for issues with mental health if there's any kind of problem with breastfeeding.
Right.
If they go into it rather with a more flexible mindset, whether that's just coming to the conclusion themselves or talking to a pediatrician or their partner, whoever about it, but being able to go into that time and saying, I would love to breastfeed and just be able to provide only that to my baby. And I'm going to try my hardest. If I need lactation consultation, I'll get it, whatever. I'm going to try my hardest. If it doesn't go the way that I would like it to go or I'm anticipating it will go, if there's problems with supply, if I don't like it, whatever, I'm fine going to formula.
Yeah.
That's a hugely different space than breast milk or bust.
Yeah. Yeah, I've heard similar sentiments from labor and delivery nurses about birth plans.
Yes.
Yeah. Like, I feel like there's this picture perfect image that especially is pushed in media around both birth and also postpartum period and breastfeeding journey and everything like that. And it just can't biologically always fit that way.
Yeah. You can always hope for it, right? You can imagine it, you can hope for it, but it's the expecting it that can really get in people's way, and the not having any kind of backup plan or flexibility about it.
Yeah, that makes sense. So how can you balance breastfeeding and mental health self-care, especially when it comes to things like sleep? Like, if you require 5 to 6 sustained hours to make a big difference in your mental health, but you have to pump and or breastfeed every 4 hours, then how can you balance it? Do you have a sleep schedule recommendation or just tips in general on how to balance the two?
Yeah. So it tends to get individualized for everybody, of course, but again, having the flexibility to think, maybe one bottle of formula overnight is not the worst thing in the world, and having a partner that, can wake up and give a bottle overnight is super helpful.
Yeah.
Whether that bottle is pumped milk or formula. if you're only breastfeeding and pumping, then you may have to sort of deal with the idea of having a lower supply, because again, you do have, just biologically, you have to pump with a certain frequency to keep up the same supply.
Yeah.
So if you are pumping every 4 hours and you decrease it, even overnight, you have a span of 6 hours. Not for everybody, but for some people that can be enough to lower their supply, and you have to be mentally prepared for that. So again, knowing that that's a possibility, and again, being open to the idea of supplementing with formula if that were to happen is really, really helpful. But then in general, I think having a shift schedule between you and your partner is really helpful for being able to meet baby's needs overnight and have everybody get 5 to 6 hours of sleep.
Yeah.
So rather than everybody waking up every time the baby wakes up, having one person be on shift for 6 hours and does everything baby needs, feeding, diaper, getting back to sleep, all of that. And then after 6 hours, they switch.
Yeah. Okay. So when I know we chatted about earlier medication, specifically SSRIs and a lot of depression and anxiety related medications being okay during pregnancy, but are they okay during breastfeeding?
Basically, yes. Again, short answer, yes.
Yeah.
Anything that you take during pregnancy is generally assumed to be fine in breastfeeding.
Okay.
Because the exposure is actually about 5 to 10 times higher during pregnancy.
Okay. Amazing. Are we good with this one?
I found, one last backup battery.
Okay, sorry.
We'll get us through it.
I feel like the wide cam isn't as important, so it should be good.
I made sure to kind of just get different angles where there's enough space, because I know you like to kind of zoom in and stuff, and so this is just these are all still rolling, been rolling, so I think okay.
Awesome. Yeah. Okay, so definitely good to know. And I know you mentioned, or we've been chatting about medications as sort of a potential resource and coping mechanism for depression and anxiety, but what resources would you recommend besides medication and seeking psychiatry help or anything like that for parents that are struggling with postpartum issues that are mental health related?
It's definitely psychiatry, therapy with a specific perinatal therapist. The online support groups, again, from Postpartum Support International, are incredibly helpful. Community, just finding community. If there are issues at home, with your partner, and that's actually really common that marriages or partnerships tend to change a lot immediately after babies. Oftentimes one of the strongest recommendations that I'm giving is couples counseling. Yeah. Really ironing out communication issues. Ideally that happens during pregnancy or prior to pregnancy, and not sort of emergently in the postpartum, because it's also much easier to do a therapy session when there's not an infant. But if it's necessary, couples therapy can be incredibly helpful.
Okay. Are there couples therapists that are also reproductive therapists or can specialize in that time?
Some do, but it's, they can have that PMHC certification. And some therapists do sort of specialize in working with parents of kids of varying ages.
Okay. Awesome. My last question is around OCD, since we haven't really touched on that prior. If you are experiencing pregnancy OCD, what are your recommended coping mechanisms for that period?
Yeah. So the impulse with OCD is to avoid the triggers that are causing this anxiety. So it can be an impulsive thought about driving with the baby and getting into a car accident. And the impulse is to then avoid driving. The avoidance is very reinforcing, kind of giving into those fears and giving them too much power is very reinforcing for them. Because then you think, oh, that's a dangerous, scary thought. I'm going to get into a car accident. If I avoid driving, that feels a lot safer. So I'm going to do that. But it just increases the anxiety the next time. So the best coping skill, and what therapy would also sort of do formally, is expose yourself to the thing that you're afraid of. Keep driving.
Right.
Sometimes people they'll see a knife on the kitchen counter and have an intrusive thought of stabbing their baby, these awful, terrible images. And so they remove all knives from sight. Very reinforcing. Keep the knife out, look at the knife, stare at the knife. And just kind of get through the anxiety that comes with it, because it will always pass. The anxiety is not going to stick around forever. It will always pass. So you just habituate yourself to that anxiety.
Yeah. Okay. I'm curious, during your pregnancy, if you experienced any mental health issues, and you don't have to answer if you're okay with it.
Thankfully, I didn't have any major mental health issues during my pregnancy or postpartum, but I had the OCD thoughts. I don't have a history of OCD. Yeah. But I had these really vivid, intrusive, immediate, automatic images of harm coming to my baby. Dropping her, down the stairs or even off the stairs. Walking past a corner of a wall, I would have an intrusive image that her head, which was, sticking a little bit off of my arm, would bash into the wall, right? These really awful thoughts. I knew what they were because I do what I do, but it's jarring to experience it.
Yeah. Was there anything that you did during your pregnancy and or postpartum that you did because you are a psychiatrist and you have your background?
I just really paid attention to how I was feeling, being mindful, being present with yourself, and really early on saying, let's not continue this. Let's get a couples therapist, iron out a few things. We met for a few sessions, got, some better communication skills, and then moved on. Yeah.
Well, thank you for sharing. I know I didn't write down any questions about your personal experience, but I was curious.
Yeah. I'm going to have to tell my husband I said that.
Cool. Well, yeah, if anyone is, especially in the LA area, or even if they're not, if you do telehealth, how can folks find you? Do you offer support to even folks outside of the LA area?
Yeah, so I have a private practice in person in Westlake Village, and then I also offer telehealth, depending on the severity of the case. I see people all over California.
Yeah.
The website for that is BrittanyBoothMD.com. And then I also want to just talk about the really wonderful resources that I'm involved with at UCLA. Yeah. So the Women's Life Center is, again, this outpatient reproductive psychiatry clinic that does essentially everything that I do in private practice. I bring it up because in my private practice, I take a couple of insurances. I take Aetna and Optum, but I don't take all insurances. And so people are not able to afford, a cash pay service, for reproductive psychiatry. Most people can't. And so UCLA Reproductive Psychiatry Clinic or Women's Life Center is a much more accessible place that people can get help, and it's, they take the majority of insurances. The wait to get in is a bit long, but it is a resource. And then for people who are having more severe problems during pregnancy or the postpartum, there's actually a program at UCLA that's a higher level of care. It's called an intensive outpatient program, or IOP, that I also work in.
Yeah.
And that is a really incredible resource for people that need just more help than outpatient therapy in psychiatry. It's 3 days a week, 2 days are virtual, and 1 day is in person at UCLA in Westwood. Moms bring their babies when they're in program on that in-person day. And it's weekly or bi-weekly psychiatry visits. So generally speaking, antidepressants are all considered to be safe to take during pregnancy. We have supportive data for all the different antidepressants really that we have on the market, especially the older ones. Some of the newer ones, we just don't have as much data on them because they haven't been around as long. But for the older ones that are well established, we have enough data to support it. Mm-hmm. There is an association with this one particular thing that I always bring up with patients, but it's not something that changes my practice at all. So there is a risk of something called neonatal adaptation syndrome, which is a cluster of symptoms that can happen to the newborn immediately after delivery. It really ranges in what it looks like. It could be more crying and irritability, difficulty with latching or sucking. They can have some motor issues or muscle tone issues. They can be either sort of floppy or a little bit more tense. Sometimes they can be grunting, which is a sign of respiratory distress. It's always time limited by itself. It goes away on its own. It doesn't require specific treatment to make it go away. Typically, if it does happen, it will last on the order of hours to days, a few hours, maybe a couple of days at most. The longest ones are like a couple of weeks at its most severe. And it doesn't require treatment to make it go away. It'll go away on its own. If it is one of the more severe cases, sometimes it can require support in the NICU, just feeding and breathing support, just to get them through that. Once it goes away, they've done these long-term studies on kids that experience it, and there's no lasting impact. They develop completely normally after that. So there is the risk of that. It also tends to be really mild. So we talk about the more severe cases of what that looks like, but it tends to be so mild that most people don't even see it. In the literature, it says that it can happen up to 30% of the time. But if you think about those symptoms, crying, difficulty with latching, they might look a little floppy or tense, that just sort of looks like a newborn. And so oftentimes it's not even recognized that it's happening clinically. And so 30% is coming from a researcher who's standing there like checking little boxes. If you ask any reproductive psychiatrist, has this happened to a third of your patients taking medication through pregnancy? Absolutely not. No one's going to say that it happens a third of the time. So people who have been doing it for decades have had maybe a handful of patients report back that it happened.
Yeah.
Regardless, it's in the literature. We know that there is an association with it, so I always talk about it. But it's not something that changes my practice at all. It's not a reason to not take medication.
Yeah. Okay, awesome.